Hello everyone and welcome to the final warm-up review for the course. Here we go. First here, what is the mechanism of action of the statin drug? So the statins inhibit HMG-CoA reductase, the rate-limiting enzyme in cholesterol synthesis, so these are used to lower cholesterol levels. Next, what are the irreversible enzymes involved in gluconeogenesis? So this is a little bit tricky. So first we have pyruvate carboxylase. That's going to convert pyruvate to oxaloacetate. Then we have phosphoenolpyruvate carboxykinase, or PEP carboxykinase, which converts oxaloacetate to phosphoenolpyruvate. Next, we have fructose 1,6-bisphosphatase is going to convert fructose 1,6-bisphosphate to fructose 6-phosphate. And then we have glucose 6-phosphatase is going to convert glucose 6-phosphate to just good old-fashioned glucose. All right, guys, that brings us to the end of our warm-up. Let's get to that video.
Well, we've made it to the very last video in the entire course. We're wrapping up the cancer drugs, starting with 3 drugs that have platinum molecules in them: cisplatin, carboplatin, and oxaliplatin. These platinum drugs work by cross-linking DNA, and I want you to remember that they have a genitourinary association. So they're used to treat testicular cancer, ovarian cancer, and bladder cancer. And then for side effects, these drugs are nephrotoxic. That's that genitourinary association again. They treat genitourinary cancers and then they cause nephrotoxicity. They can also cause acoustic nerve damage, so they're also ototoxic. Now, we've mentioned several drugs throughout the course that are both nephrotoxic and ototoxic: vancomycin, aminoglycoside antibiotics, and loop diuretics. And then here, we're adding cisplatin and carboplatin to that list. The next drugs are etoposide and teniposide, which inhibit the enzyme topoisomerase II. Topoisomerase II is the enzyme that undoes the upstream supercoils as you're unwinding and replicating DNA. And if you can't relieve that supercoiling, you won't be able to replicate DNA, so cell division shuts down. Now, the name etoposide helps you to remember the mechanism of action. Etoposide has top in the name, so it's going to help you remember that it's inhibiting topoisomerase. And if you think back to microbiology, can you remember a class of antibiotics that also inhibits topoisomerase? Fluoroquinolones. Now, we use etoposide to treat small cell lung cancer, prostate cancer, and also testicular cancer. We keep coming back to drugs used for testicular cancer, and not by accident. Testicular cancer isn't really a tremendously common cancer, but for some reason, Step 1 likes to ask you about treating testicular cancer. There are several common regimens used for testicular cancer that include etoposide. One of these is a regimen of etoposide plus bleomycin plus cisplatin. Now, there's a great mnemonic that somebody sent in several years ago. It's a little crass, but it's really memorable. The mnemonic is eradicate ball cancer, which stands for etoposide, bleomycin, and cisplatin. And don't forget that we said ifosfamide can be used for testicular cancer. So there's another regimen where you replace the bleomycin with ifosfamide. So it's etoposide plus ifosfamide plus cisplatin. When I said that etoposide and teniposide inhibit topoisomerase II, that's true, but there's also a related enzyme called topoisomerase I, and there are 2 drugs that inhibit this: irinotecan and topotecan. And again, there's a clue in the name. Topotecan inhibits topoisomerase. Now, I'm not going to get into the difference between topoisomerase I and topoisomerase II because it's not really important for Step 1, but I want you to know that these 2 drugs, irinotecan and topotecan, inhibit topoisomerase I. Now, irinotecan is mainly used for metastatic colon cancer, and then topotecan is used for small cell lung cancer, ovarian cancer, and cervical cancer. The next few drugs all work by affecting the function of microtubules, starting with vincristine. Vincristine and vinblastine are called vinca alkaloids because they come from vinca plants, which is a type of periwinkle. Vincristine blocks the polymerization of microtubules. That's an important mechanism to know. Microtubules polymerize to form mitotic spindles, which then pull the chromosomes apart during mitosis. So if you can't polymerize the microtubules, there's going to be no mitosis and therefore no cell division. So vincristine is used to treat Hodgkin lymphoma, Wilms tumor, Ewing sarcoma, and also choriocarcinoma. So what was the drug we talked about in the last video that we said could also be used to treat those childhood tumors like Wilms tumors and Ewing sarcomas? It was dactinomycin. Remember, children act weird. The ACT is for dactinomycin, and then weird stands for Wilms tumor, Ewing sarcoma, and rhabdomyosarcoma. Now, do you remember the other drug we mentioned for treating choriocarcinoma? It was methotrexate. And then for side effects, vincristine causes some neurotoxicity and peripheral neuritis. Then the other vinca alkaloid is vinblastine, which works very much in the same way. It blocks microtubule polymerization and prevents mitosis. It has basically the same indications as vincristine. But the thing that distinguishes vinblastine is that it causes myelosuppression. So you might remember the phrase, vinblastine blasts bone marrow. It's myelosuppression. There's also paclitaxel, plus a handful of similar taxols or taxanes. These are also drugs that act on the microtubules, but in a totally different way. Remember, we said vinca alkaloids block microtubule polymerization, but paclitaxel and the taxols hyperstabilize the microtubules. So the cells build microtubules by stacking these polymers on top of each other. Then they have to be broken down again after they're used. So vincristine and vinblastine block the formation of the microtubules, and taxols hyperstabilize the microtubules so that they can't be broken down, and that interrupts mitosis. Now, a couple of years ago, a student suggested a mnemonic that says that taxes are used to stabilize society. So that can help you remember that paclitaxel stabilizes microtubules, unlike vincristine and vinblastine, which block the formation of microtubules. Now, paclitaxel is used mainly to treat ovarian cancer and breast cancer. And as a side effect, it can cause myelosuppression and also hypersensitivity reactions. Now, let's quickly review some other drugs that interfere with microtubules. We've just mentioned vincristine and vinblastine and the taxols like paclitaxel. Then there's also the antihelminthic drugs like benzimidazoles, like bendazole and albendazole. There's griseofulvin, which is an antifungal drug that interferes with microtubules. And then the gout drug colchicine interferes with microtubules as well. So it's a short list, but make sure you know those drugs that interfere with microtubules. The next drug is hydroxyurea. And we talked about hydroxyurea as a drug that you give to sickle cell patients to increase hemoglobin F production. But it can also be used to treat myeloproliferative disorders such as CML. This drug inhibits ribonucleotide reductase, so it inhibits DNA synthesis. The next two drugs are selective estrogen receptor modulators, or SERMs. We touched on these in reproduction when we talked about breast cancer. Tamoxifen is an estrogen receptor antagonist in the breast, but it's an estrogen agonist in the bone. And in the endometrium, it's a partial agonist. So it's selective in how it acts at different estrogen receptors in different tissues. So we use tamoxifen to treat estrogen receptor positive breast cancers. If the breast cancer doesn't have estrogen receptors, tamoxifen isn't going to help. And sometimes you can actually give tamoxifen to prevent breast cancer in patients with a BRCA mutation. Tamoxifen may increase the risk of endometrial carcinoma because it has a partial agonist effect on the endometrium. But we sometimes use tamoxifen off-label to treat women with advanced endometrial cancer. Now, that's potentially confusing, so let me break it down for you. If you do not have endometrial cancer, tamoxifen could overstimulate the estrogen receptors in the uterus and cause endometrial proliferation and endometrial cancer. But if you do have endometrial cancer, because tamoxifen is only a partial estrogen agonist at the uterus, it stimulates the estrogen receptors less than the patient's native estrogen would, so it can be used to treat endometrial cancer. So to say it one more time, tamoxifen could potentially cause endometrial cancer in women who don't have cancer, but in women who do have endometrial cancer, tamoxifen can be used to treat it. But again, the main use for tamoxifen is in breast cancer. I'm sure you know that. The other SERM to discuss is raloxifene. Raloxifene is mostly used to treat osteoporosis, not cancer. It's an estrogen antagonist in the breast and an agonist in the bone, just like tamoxifen. But the difference is that raloxifene is an antagonist on the estrogen receptors in the endometrium. Again, these drugs are selective. So if you have a postmenopausal woman with an intact uterus that wants to go on a SERM for osteoporosis prevention, raloxifene is perfectly safe. Another drug used exclusively to treat breast cancer is trastuzumab. Trastuzumab ends in mab, so you know it's a monoclonal antibody. It's a monoclonal antibody against HER2, which is a growth factor receptor. And we use it to treat breast cancers that overexpress HER2. If the cancer does not express HER2, then trastuzumab is going to be ineffective. So we always test breast cancers for estrogen and progesterone receptors and for the HER2 new mutation. If it's estrogen receptor positive, ER positive, we're going to give tamoxifen, and if it's HER2 positive, we can give trastuzumab. And then for side effects, trastuzumab is cardiotoxic. Herceptin hurts the heart. Now, what other cancer drugs did we say are notoriously cardiotoxic? cardiotoxorubicin, right? Doxorubicin and daunorubicin. Now, we have a few more drugs to discuss, but first, let's pause and do a whiteboard review. For this review, I've listed some of the mechanisms of action on the left, and we're going to match the drugs to each one of these. So the first one inhibits microtubule formation, that's vincristine. And then the one that inhibits microtubule disassembly is paclitaxel. Remember we said taxes stabilize society. So the taxanes and taxols stabilize microtubules. They inhibit microtubule disassembly. Next one is inhibits ribonucleotide reductase, that's hydroxyurea. Then the one that inhibits topoisomerase 1 is topotecan, and that means the one that inhibits topoisomerase 2 is etoposide. Now on this page I've listed some notable side effects in black over on the left, and then some possible drugs that could cause that side effect, and I want you to choose the correct answer. So the first one is cardiotoxicity, and our choices are tamoxifen, trastuzumab, and teniposide. And this one is trastuzumab. Remember the brand name for trastuzumab is Herceptin, and Herceptin hurts the heart, so that's cardiotoxicity. The next side effect we have here is hypersensitivity reactions, and our choices are paclitaxel or vincristine, and this is paclitaxel. Now I know hypersensitivity reactions sounds kind of vague and nonspecific, but those hypersensitivity reactions are really a big problem with the taxanes, and that's worth knowing. The next one is increased risk of endometrial cancer. We said that was a problem with tamoxifen because tamoxifen is an estrogen receptor antagonist in breast tissue, but it's a partial agonist in the endometrium. And remember, raloxifene isn't. The next one is nephrotoxicity and ototoxicity. And our choices are etoposide, bleomycin, and cisplatin. The answer here is cisplatin and the other platinum-containing cancer drugs. Remember that cisplatin has this genitourinary association. Remember, cisplatin is nephrotoxic. And it can also be used to treat bladder cancer and to treat testicular cancer. Now maybe you recognize these drugs from the mnemonic eradicate ball cancer. Etoposide, bleomycin, and cisplatin. And what was the important side effect to remember for bleomycin? Think about Lance Armstrong. Bleomycin causes pulmonary fibrosis. Got to know those side effects. All right, and our last side effect here is peripheral neuropathy. And we have paclitaxel and vincristine, and this one is vincristine. So again, make sure you know all those side effects. Now we're going to talk about a bunch of drugs used to treat leukemias and lymphomas, starting with rituximab. We said that drugs that end in mab are monoclonal antibodies, and rituximab is an antibody against CD20. So that's easy to remember if you pronounce rituximab as rituximab or rituximab, like the number 2 and then the Roman numeral 10 or X. So 2 times 10 is 20. So rituximab or rituximab is an antibody against CD20. And CD20 is a B cell marker. So we use this drug on B cell tumors such as lymphomas and leukemias. And it's also used to treat certain autoimmune diseases like rheumatoid arthritis and some types of vasculitis where you want to suppress the immune system. And then it can be used off-label for things like pemphigus vulgaris and ITP and all sorts of unusual things. You might also remember the drug imatinib as a drug used to treat certain types of leukemia. Now imatinib ends in ib, not mab. So this is not a monoclonal antibody. This is an enzyme inhibitor. IB for inhibitor, ib. Imatinib specifically targets the mutant BCR-ABL tyrosine kinase that's produced by the Philadelphia chromosome. So when you hear Philadelphia chromosome or translocation 922, I want you to remember Philadelphia cream cheese, which reminds you of which type of malignancy? CML. So we see Philadelphia chromosome in CML mainly, but sometimes ALL, and then AML could sometimes have a positive Philadelphia chromosome as well. So in those cases, you could use imatinib. Another type of inhibitor that ends in ib that we use to treat certain lymphomas are the proteasome inhibitors. Now, do you remember what a proteasome was? We covered this way back in Foundations. A proteasome is an intracellular protein complex that degrades damaged or obsolete proteins within the cell, proteins that have been tagged with ubiquitin to mark them for demolition. So proteasomes are kind of like the bulldozers that break down these damaged proteins. And without getting into the nitty-gritty details, when you block proteasomes with bortezomib, it arrests the cell cycle, so the cell can't progress into M phase, and it triggers apoptosis. Now, we use these drugs to treat multiple myeloma primarily, and also to treat mantle cell lymphoma. And the side effects include peripheral neuropathy and also an increased risk of shingles, or herpes zoster. You'll also see glucocorticoids like prednisone used to treat lymphoma because they can trigger apoptosis in lymphoid cells. Glucocorticoids inhibit apoptosis of neutrophils, but they trigger apoptosis in lots of other cells, such as lymphoid cells. So we use prednisone in lymphoid tumors like CLL and Hodgkin lymphoma. Makes sense. And it's definitely high yield to know the toxic side effects of prednisone and other glucocorticoids. Now, we've been through these side effects before, but as a recap, we use the mnemonic BAM Cushingoid to stand for buffalo hump, amenorrhea, moon facies. The C is for crazy, to help us remember the psychosis and agitation that some people get on steroids. The U is for ulcers, peptic ulcers. The S is for skin changes, such as acne, purple striae, thinning of the skin, and easy bruising. Then there's hypertension, infection, necrosis of the femoral head. The G stands for glaucoma and cataracts, which are both eye problems. And then osteoporosis, immunosuppression, and diabetes. So make sure you know all of these side effects. Very important. So if you're treating lymphoma or leukemia and you're triggering apoptosis with prednisone and all these tumor cells lyse, the patient can end up with a dangerous emergency situation called tumor lysis syndrome. As all those cells lyse, their intracellular contents spill out into the blood. So when nucleic acids are released in large quantities from DNA and RNA, the purines are metabolized by xanthine oxidase to become uric acid, which precipitates out in the kidneys and causes nephropathy and acute kidney injury. The release of potassium leads to hyperkalemia. The release of phosphates leads to hyperphosphatemia. And then all that phosphate can sequester the patient's calcium, and that leads to hypocalcemia. Now, tumor lysis syndrome is especially problematic when treating Burkitt lymphoma and ALL, acute lymphoblastic leukemia. So, when you're starting treatment for cancer, you want to assess the patient's risk of developing tumor lysis syndrome. So do they have a type of cancer that's prone to tumor lysis syndrome? Do they have pre-existing hyperuricemia or hyperkalemia or some pre-existing renal insufficiency? And if they are higher risk, we try to prevent tumor lysis syndrome by making sure the patient is adequately hydrated, by giving allopurinol, which inhibits xanthine oxidase, so it prevents the formation of uric acid, or we can give a drug called rasburicase. Now, rasburicase is a recombinant version of the enzyme urate oxidase, or uricase, which is an enzyme that breaks down uric acid into a chemical called allantoin, which is then converted to ammonia and excreted in the urine. So basically, in tumor lysis syndrome, there's so much uric acid produced that it overwhelms the body's natural uricase. So we give recombinant uricase, or rasburicase, to help break down the uric acid and facilitate elimination. So allopurinol blocks formation of uric acid. Rasburicase speeds up the breakdown of uric acid. Okay, back to a few more monoclonal antibodies and inhibitors. These are newer drugs that aren't really very high yield yet, so it's really just a few facts to be aware of for each one of these. So there's a drug called bevacizumab, which is a monoclonal antibody against VEGF, which is vascular endothelial growth factor. Back in Foundations, we talked about how VEGF causes proliferation of the vascular endothelium to create new blood vessels. Well, cancers need new blood vessels in order to keep growing. So some cancers make VEGF. So if you give bevacizumab to bind up that VEGF, the cancer won't be able to grow new vessels, and the cancer cells will die. So bevacizumab is mainly used to treat metastatic cancers and advanced treatment-resistant cancers, especially metastatic colon cancer, metastatic cervical cancer, certain types of lung cancer, and metastatic renal cell carcinoma. But all these are solid tumors as opposed to the leukemias and lymphomas that we've just been talking about. Now, for the side effects, you have to worry about impaired wound healing because healing wounds use VEGF to grow new vessels too. So you don't want to give bevacizumab to a post-op patient or a patient who's about to have surgery. But advanced metastatic cancer isn't usually treated surgically. And it can also cause severe hemorrhage, especially hemoptysis, epistaxis, and GI bleeding. There's another monoclonal antibody called cetuximab, which is an antibody against a growth factor receptor called EGFR, epidermal growth factor receptor. Now, this is part of a very important family of receptors that are all tyrosine kinases, just like the BCR-ABL Philadelphia chromosome. But overexpression of EGFR is common in lots of tumors. They're part of growth factor signaling, right? So they make cells grow and proliferate, which is cancer in a nutshell. So we give cetuximab to bind to those receptors and shut down this tyrosine kinase growth factor signaling cascade, and it shuts down tumor growth. It's particularly useful to treat advanced metastatic colon cancer, specifically colon cancer associated with the KRAS oncogene. And it's also used for squamous cell head and neck cancers, again, advanced metastatic tumors. And there's an inhibitor drug that works on the same EGFR mechanism called erlotinib. Erlotinib inhibits this EGF receptor directly, so again, it shuts down the signaling cascade and reduces the cell's response to that growth factor signal. This is especially used in non-small cell lung cancer, and it's worth knowing that it causes a bunch of different rashes and skin disorders as side effects. So you might remember that erlotinib causes a lot of different rashes. Probably the most important rash is one that looks a lot like acne, especially on sun-exposed areas like the neck and the upper chest and the face. And there are several similar drugs in this family, a handful of drugs that are monoclonal antibodies against EGFR, like cetuximab, and a handful of EGFR inhibitors, like erlotinib. And finally, there's vemurafenib, which is an inhibitor of an oncogene product called BRAF. So this is another protein kinase signaling protein, not a tyrosine kinase, but a serine threonine kinase. And vemurafenib is used to treat advanced metastatic melanomas that have a certain mutation in that BRAF oncogene. So that does it for our cancer drugs. Now let's take a look at our very last end of session quiz. First question, which anti-cancer drug fits each of the following descriptions? Cross-links DNA and is nephrotoxic and ototoxic. This is cisplatin, carboplatin, and oxaliplatin. Prevents tubulin disassembly is paclitaxel and the other taxols. Remember, taxes stabilize. They stabilize the microtubules. They prevent disassembly of microtubules. Inhibits ribonucleotide reductase is hydroxyurea. Inhibitor of the mutated tyrosine kinase produced by the Philadelphia chromosome, that's imatinib. Monoclonal antibody against HER2 is trastuzumab. And the serum that does not increase the risk of endometrial cancer is raloxifene. And our last question, what are the possible side effects of glucocorticoids? Bam! Buffalo hump, amenorrhea, moon facies, crazy, which is psychosis and agitation, ulcers, skin changes, hypertension, infection, necrosis of the femoral head, glaucoma and cataracts, osteoporosis, immunosuppression, and diabetes. And that brings us to the end of oncology. Thanks for sticking with us to the very end. Now I'm going to turn it over to Dr. Jenkins, who has some final thoughts for you.
All right, so that brings us to the end of oncology, and if you've been watching the videos in consecutive order, that also brings us to the end of our doctorsintraining.com Step 1 review course. I'd like to say thank you for your time and for seeing the course through to the end. I hope you've learned some new information from the course and feel extremely confident going into your Step 1 test, knowing that you're well prepared and that you studied the right information. I know that your effort in completing this course will be rewarded with your best possible Step 1 score. We'll be sending you a survey to help us make the course better and better each year, so when you receive the survey, please complete it and mail it back to us. Continue studying up to your test day, and good luck on your exam. We hope to see you next year when you prepare for Step 2.